Hi everyone. Thanks so much for having me this afternoon. I'm very excited to speak with you today about narcolepsy medications. A couple quick notes to start. Firstly, I'll only be using generic names of medications in this presentation, so you may know some of these medications by other names, like their trade name, and solely for the sake of impartiality, I'll be avoiding using the trade names in this presentation. And secondly, it's important to note that medications in narcolepsy are very individualized, and it truly is sort of the art of medicine, as we say, and very personal to each patient involved. And so this presentation is not meant as medical advice, more of as an overview to give you some extra information about these particular medications used in this condition. A final note briefly is that I'm very far north in Iqaluit, Nunavut, and that is the reason why this is a pre-recorded presentation. Sometimes the bandwidth up here isn't quite as reliable as it would be down south, and so I'm recording this a few days in advance, although I am available for questions at the end. So we're going to start by talking about physiology of narcolepsy in the sleep-wake system, particularly as it relates to various targets of the medications. We're going to talk about the main symptoms of hypersomnolence, meaning daytime sleepiness, and cataplexy, and then the medication with the focus on these troublesome symptoms and how the medications address these, and then finally pairing this with some non-pharmacological, meaning non-medication related alterations to lifestyle and some special considerations for particular populations. So to start off with the physiology, there's many wake-promoting neurotransmitters that are kind of spread in networks throughout the brain. The main ones listed here, norepinephrine, dopamine, serotonin, and histamine, spread out throughout sort of the frontal lobes and the wake-promoting centers, and are very important in our experience of the world and wakefulness. And the key here as well, you can see in the mid part of the brain here, this little hormone called orexin, which is essentially a stabilizer that works with these wake-promoting neurochemicals to help keep us awake day to day. Narcolepsy in itself is not necessarily a problem with sleep. It's a problem with sleep and wake stabilization. So think of it as a teeter-totter. In most people without narcolepsy, sleep and wake are two mutually exclusive conditions, whereas when your stabilizer, meaning orexin here, is not necessarily functioning the way it should, or the receptors are not necessarily functioning the way it should, then this balancing act becomes a little bit more difficult. So narcolepsy is not just a problem of sleep intruding into wake, but also wake intruding into sleep and sleep states intruding into wake. So it's a problem with this teeter-totter, if you will. There's two main types of narcolepsy, as you may know. So both of these types are involved with hypersomnolence or daytime sleepiness as the classic symptom that a lot of people experience and a lot of people know about. Additionally, both types will have REM intrusion, so REM being your rapid eye movement sleep, your dreaming sleep. And so this is characterized by things like hypnagogic hallucinations, seeing things at night as you're falling asleep, or sleep paralysis. And there is also an element of sleep-wake instability. So in the same way as sleep intrudes into wake, wake intrudes into sleep and can cause sleep to be somewhat disrupted and fragmented throughout the night. Now, type 1 narcolepsy is defined by low CSF, so cerebrospinal fluid, the fluid around the brain, orexin, and this presents itself with a symptom of cataplexy, which we'll talk about briefly when we talk about the medications, whereas type 2 is narcolepsy without cataplexy. So in terms of these main symptoms, the most common symptoms and troublesome symptoms that we often try to address with medications are hypersomnolence or daytime sleepiness, which is the trouble with this sleep-wake flip-flop switch. So as I've said before, sleep intruding into wake manifesting as sleepiness, and wake intruding into sleep manifesting as sleep fragmentation. Cataplexy is inappropriate activation of REM paralyzing system in the brain and spinal cord. So as you can imagine, in your dream state, it would not be protective for you to thrash out and move about and act out your dreams as your brain is actively experiencing those movement impulses, and so your spinal cord needs to be paralyzed in order for that to be productive. But if your spinal cord is incorrectly paralyzed during wakefulness, then that's when you get something called cataplexy. And this can be quite troubling in patients with type 1 narcolepsy and potentially even dangerous, and so it is often a symptom that we address with medications. There are additional symptoms as well to narcolepsy that are sometimes thought about a little bit less in terms of the main presenting symptoms. So people with narcolepsy sometimes will have more difficulties with weight control. So the hormone systems that are involved, particularly in children, tend to lead to troubles with weight management. People with narcolepsy are also known to have lower pain thresholds and can experience chronic pain syndromes such as chronic migraines or fibromyalgia or other pain syndromes. People with narcolepsy are more likely to have mood disorders as well, and whether this is an effect of having a chronic disease or narcolepsy itself is a bit unclear, but it often does come with the condition. And then finally, people with narcolepsy are also more likely to have other sleep disorders. So sleep apnea and insomnia in particular are common in this population. So let's talk about the crux of the matter, the medications. So first we're going to be addressing hypersomnolence, daytime sleepiness. And there's some tried and true medications, so modafinil and stimulants, methylphenidate, dextroamphetamine, lisdexamfetamine. And then there's some brand new ones as well. So solriamfetol and pitolisant are some medications that have really only been approved over the past couple years. So they're sort of the new kids on the block to talk about. Modafinil promotes alertness by several neurotransmitter pathways, but largely dopamine, and it's a very highly effective and widely used medication. It's viewed as a wake-promoting substance, not necessarily a stimulant. The medication is available in tablets, either 100 milligrams or 200 milligrams, and it's taken 1 to 2 times per day. Often there's a dose in the morning and then an as-needed PRN dose in the afternoon, usually at around noon. It takes about 2 hours to take effect when it's taken first thing, and it can be a little bit delayed if you take it with food, so it's important to consider the daily schedule around the administration as well. It lasts about 8 hours, but this will be different person to person in the variable ways that it affects someone. Someone might experience the effects a little bit longer, some people a little bit shorter. And the final thing that's important to note is it's not overly costly, so when you look it up on the formularies, at least in Ontario, it comes out to about $1 a pill for either the 100 or 200 milligram doses. There are some important side effects to know about, so headache, nausea, and insomnia are the most common side effects. In younger people, particularly our pediatric population, severe rash, something called Stevens-Johnson syndrome, has been reported with this medication, so it's something to keep eyes out for if it's a new medication started, and we always counsel our patients on this. It's really as well important to note for family planning. Not only does modafinil interact with oral contraceptive medications, but it can also be harmful to a developing fetus. So in people who may become pregnant who are on this medication, it's very important to have an alternative form of birth control, such as an IUD. And it's worth noting as well that other hormonal types of birth control, like the depot as well, it's not incredibly well known, but in general the advice is that modafinil will most likely interact with it, and so having an alternate method of birth control is very important. Next, we'll talk about stimulants. So this is a class of medications, and there are several medications that fall under this umbrella. So methylphenidate, dextroamphetamine, mixed salts amphetamines, and lisdexamfetamine are the common ones that are used. These are very widely available and generally more affordable. So anywhere from 10 cents for the immediate release tabs to 30 cents for a sustained release 10 milligram methylphenidate tab. So it's a little bit more available if you're someone who doesn't have access to health coverage. They're available in both immediate release and controlled release forms. It's important to note that these are controlled substances for a reason. There is abuse potential, and there is potential for tolerance as well. So this can complicate the prescription sometimes, meaning that it may be difficult to fill this prescription in advance. If you are going on a long trip, for example, and you need to fill a couple weeks early. So these are considerations that are important to make, and just to know that you may require a bit of extra planning or discussion with your physician. The most common side effects are associated with the stimulant properties of these medications, so decreased appetite, sometimes headache, anxiety, or in people who are a little bit more prone to it, it can even provoke an episode of mania. Heart palpitations as well, and high blood pressure. So people who already have troubles with high blood pressure, for example, or have cardiac heart comorbidities, this might not be the best medication in that particular population. There are some differences between the immediate and the continuous or sustained release forms. So the immediate release are typically a little bit less expensive and more affordable, and they have quite quick onset. So onset within about half an hour or so, and will only last a couple hours at a time. That being said, they also tend to have a quick offset and can lead to a crash and a rebound, if you will. So the place that these usually have in therapy is as an as-needed or PRN dose. So, for example, somebody who has to get to hockey practice, drive their kids to hockey practice at 6 p.m. or 7 p.m. when they would otherwise be quite drowsy, thinking about modafinil, for example, that has a much longer effect. These are medications that can be used in that type of situation. Continuous release is sort of the other side of that coin, where they're a bit of a longer effect. They tend to not have as much of a crash on the other end because they're slower on and slower off. So these can be very effective medications to be used as well for hypersomnolence. Finally, we have our newer options. So pitolisant is a medication that works through a novel mechanism. So whereas before these medications were kind of sprinkles of dopamine and norepinephrine and serotonin, pitolisant works via the histamine system. It is also approved for both hypersomnolence and cataplexy, which all of these other ones are simply for hypersomnolence. The onset is anywhere from 2 to 5 hours, and it is quite long-lasting. It is very expensive as a new medication, and I can say from personal experience, I've had some trouble with various private insurance companies covering this medication, at least so far. Now, that being said, it's very new, and that tends to happen with new medications. And over time, as we begin to use them more and paperwork gets processed, they can be a bit more accessible. But certainly for people without private health coverage, it may be prohibitively expensive. One thing to note about pitolisant is that it does interact with other medications, including birth control. So hormonal birth control, again, may be less effective on this medication. It's not actually known, as opposed to modafinil, which is known to possibly cause negative effects on a developing fetus. We don't know as well for pitolisant what the effects might be. There are side effects similar to the other ones. Headaches, anxiety, palpitations are the most commonly reported, although there is a whole list of side effects that can be reviewed with your physician if you're interested about this medication. The second new medication is something called solriamfetol. It's a bit of a mouthful, but fun to say once you get it. So it works similarly to stimulant type medications, so dopamine and norepinephrine kind of increasing those wake promoting neurochemicals in the brain. It's relatively quick onset within a couple hours, and it has a pretty long lasting effect. It is also reasonably expensive as a new medication, but again, this one is it's more and more commonly being covered by those private drug plans. Again, probably not something that would be feasible for somebody who doesn't have private health insurance, but certainly these things develop over time and may be an option in the future. It does not interact with other medications quite as much. So as opposed to the other ones where you have to be very careful, solriamfetol has a fairly limited list of other medications that it interacts with. The main ones that I've pulled out to emphasize here are herbal products, particularly herbal products that can cause high blood pressure are recommended to be very carefully used with solriamfetol, if not stopped altogether. So for example here, ginseng, arnica, ephedra, and licorice are all herbal supplements that can actually raise your blood pressure. And then the other one is dopamine agonists, so something like pramipexole. These medications can potentially interact with solriamfetol by that dopamine mechanism and can cause dangerously high blood pressure. The main side effects listed are headache, and I do have to say in the experience that I've had, headache does seem to be a bit more of a common one, but in people who tolerate it well, they do really well in this medication. Also anxiety and high blood pressure being the main other side effects. So we've spent some time talking about hypersomnolence or daytime sleepiness, and now let's talk about cataplexy. So as I mentioned, cataplexy is that paralysis of the spinal cord that acts as a normal protective mechanism for people when they are asleep in their REM dreaming sleep, protecting them from lashing out and acting out their dreams. But it can be triggered during wakefulness in patients with narcolepsy, often by strong emotions, usually mirth. So if something is particularly funny and the person is laughing a lot, that can trigger an episode of cataplexy in which it can be either full body becomes paralyzed or simply just part of the body, like a head drop or weakness of arms or legs. So there's three main types of medications that can be used to treat cataplexy. The first are SSRIs, selective serotonin reuptake inhibitors, and SNRIs as well. There are TCAs, tricyclic antidepressants. And then there's the sort of other group, sodium oxybate and pitolisant. So first we'll talk about this antidepressant category. So first you've got your serotonin plus or minus norepinephrine reuptake inhibitors, the most commonly used being venlafaxine or fluoxetine. Duloxetine is another one that can be commonly used. And these typically are the first line agents to treat cataplexy because they tend to have a really quite a well-established safety profile. So these are usually very well-tolerated medications and in a lot of people can be very effective. They can also co-treat mood disorders such as anxiety or depression that are sometimes more common in people with narcolepsy. The main side effects are troubles with sexual side effects, so troubles with sexual dysfunction, dizziness as well as a common complaint, as well as sleep disruption in the night. So it can take form as either insomnia or worsening of daytime sleepiness. The next option is tricyclic antidepressants. So as opposed to the SSRIs and SNRIs that are the most commonly used, TCAs tend to be the most effective, but they're less commonly used because the side effects are sometimes more troublesome to people. So the main side effects of these are dry mouth, constipation, sometimes drowsiness or dizziness, and particularly in older patients, they can cause confusion. So these are really good medications and very effective, but sometimes aren't the best option in people who are particularly prone to medication side effects. Next we have sodium oxybate. So sodium oxybate is a very strong sedating medication, and the actual mechanism of action isn't incredibly well known, but we believe it exerts its function by essentially consolidating nocturnal sleep. So instead of having this very broken, fragmented sleep at night, patients with sodium oxybate are able to get that nice consolidated full night of sleep. So this is a medication that's indicated for both hypersomnolence and for cataplexy. It is highly regulated, so it requires a learning course or at the very least learning material to be provided to the patient and a designated prescriber. So it cannot be prescribed, for example, by family physicians. It must be prescribed by somebody with expertise in sleep medicine who they themselves have gone through this course and are able to provide patients with that education required. Because of the safety issues, it is delivered directly to the home as opposed to picking it up at a pharmacy, which in some cases can be very convenient, as opposed to other cases when this might mean that you have to be there for the delivery. So depending on your lifestyle, it may or may not be more convenient. It is in a liquid format that can taste, unfortunately, very salty. And generally it's taken in 2 doses, so one immediately before bed and then a second dose 4 hours later. So generally patients will set an alarm or have a partner wake them up to help them take the second dose. There are some prominent issues with this medication. First of all, it is expensive. It can be covered and there are good coverage plans, but it can be a bit more expensive out of pocket. There are safety concerns. So because it's associated with such strong sedation, it should not be taken, for example, by patients who are living in a bit of a more public area. So for example, university students in a dormitory, or an area where they may be at risk if some nefarious activity were to happen, somebody breaks into a house, something like that, is important to consider. Secondly, in the event of an emergency, so for example, if there is a fire in the house, the patients may be so sedated that they are not able to wake themselves to get to safety. So generally, we recommend that these medications are taken by somebody who has somebody else in the house to help them out in that type of situation. The final safety consideration that I don't have a bullet there for is simply where and when the medication is taken. Because it acts so quickly and so effectively, it must be taken in bed, as the person may fall asleep immediately on taking it, and if they happen to be on the other side of the room, they may fall and sleep on the floor for a period of time, which can be damaging to joints and muscles. Additional considerations would be for medical comorbidities, meaning other diagnoses that people may carry. So because of the high salt content, this is not a good medication for people who might have heart disease or kidney disease. There are some side effects with this medication, aside from the strong sedation. It can be associated with tremor, dizziness, in rare situations, sleepwalking, or even sleep eating, and occasionally bedwetting as well, if somebody is not able to wake themselves to use the washroom. Usually that can be well managed by planning ahead of time and using the washroom before bed. So finally, we're going to talk about some lifestyle notes now that we've gone over the major classes and symptoms that are treated with the medications. So first of all, it's really important to optimize medication, and this is often a collaboration between a patient and their sleep physician to find the best way to optimize their medication schedule and the types of medications that they take. So number one is the first medication that somebody tries might not be the best medication for them, and to try a couple is sometimes warranted. Now, that being said, sometimes people try and the very first medication works excellently for them, and so it really is just a personalized approach. The second point is to learn how to adjust the schedule around the medication. So some people may find that a medication has a much longer effect. So they find that the modafinil dose at 12 p.m. just doesn't work for them because they cannot fall asleep at night. So maybe taking it a bit earlier, or combining medications. So for example, a common combination that is often used would be, for example, modafinil plus immediate release short-acting methylphenidate. Can be a good combination. One is a longer acting every day, and then the other is an as needed. So learning how to adjust the medications to your lifestyle, as well as sometimes learning how to adjust your lifestyle to the medications. And then finally, it's really important to use the medications in combination with lifestyle considerations. So having a consistent bedtime and following appropriate sleep hygiene methods, keeping physically active during the day, because your health is so important for a chronic condition. It's not just the medications that are working here to help optimize symptoms. There are some considerations in people who may become pregnant. So it is important to note that some of these medications may be harmful to a developing fetus. So most of these medications are either what we call category C, meaning there's some evidence of possible negative effects in animal studies, but no clear human studies to show this, or unknown risks. So those are typically the newer medications where there's just not enough data to know for sure. I think it is really important to note that while there is a potential risk for harm, there's also a risk of harm if a patient feels so unwell that they aren't able to take care of themselves, do the things they need to do without their medications. And so it is always a balance, and it's always an important consideration to discuss with your prescribing physician. So some people, they are really stable, doing really well on their medications, and they decide not to stop them. Whereas some people don't want to take any risk, and they would prefer to have lifestyle considerations and alterations such as regular naps during the day and non-pharmacologic means. And ultimately it comes down to a personal decision about your own risk tolerance in discussion with the physician who can help guide you and advise you. The other consideration for people who may become pregnant would be the interaction of these medications with birth control. So the two specific ones being modafinil and pitolisant, which can interact with hormonal birth control and reduce the efficacy. So overall, just the most important thing is that this should be an open conversation between you and your prescribing physician. The other major population group here would be elderly patients. Narcolepsy, generally being a chronic condition, can persist into old age, and so knowing how to adjust the medications as a patient gets older is very important. So first of all, generally as people get older, they may start to accumulate health conditions, and then they may start to also accumulate prescriptions and other medications that they may need to take. So it's always important to review this generally with the pharmacist as well as with the prescribing physician to see if there's any interactions between the medications. The next consideration would be side effects, and because the metabolism, the way that patients break down medications changes over time, medications may have more side effects in elderly patients. Kidney and liver function may change as we age, and the medications may be broken down differently, so sometimes dosage adjustment is required. And then finally, as everyone gets older, not simply people with narcolepsy, we all are at higher risk of sleep disorders, and that includes people with narcolepsy may develop other things like sleep apnea or insomnia or restless legs, and sometimes as the disease evolves over time, it may be harder and harder to get a handle on symptoms with medications, and that's when you need to step back and ask, is this all the narcolepsy, or is there something else going on with the sleep? Just because you have one sleep-related diagnosis does not preclude other sleep-related diagnoses. So it's always important to keep those things in mind and to sort of take ownership of the extra things on sleep, like sleep hygiene and getting sufficient sleep and those things to help address that in the future. And then finally, we have some lifestyle considerations. So firstly, it's very important to protect nighttime sleep, to ensure sufficient sleep, and really emphasize the importance of that nighttime sleep. So everyone will be tired when they get 6 hours of sleep, and add that on to a sleep condition like narcolepsy, and it can certainly add up. The next point you can't quite see because it's hidden behind me there is support. So with any chronic condition, including narcolepsy, it's very important to have social supports as well as professional supports. And I'm very thankful for Wake Up Narcolepsy One as a professional organization that helps provide support to patients with narcolepsy. Physical health is very important, as with any medical condition. So regular physical activity, healthy diet, and an emphasis on health at whatever size you may be at, knowing that patients with narcolepsy may be more at risk of gaining weight. So just to be mindful of that in the future. Medical conditions are commonly comorbid, as in come together with narcolepsy, so mood disorders like anxiety and depression, which can sometimes present as sleepiness. Migraines and chronic pain should be treated, and so follow up as needed with sleep physician and family physician to consider additional medical considerations. It's really important to work both with your sleep physician and with your workplace on workplace accommodations. I have some patients who have very accommodating workplaces, and they're able to take naps throughout the day. They lengthen their workday a little bit and nap throughout the day, and it really reduces their need for wake-promoting medications, and so they're able to manage their symptoms really well just with lifestyle modifications. It's important to know that this is a possibility, and certainly as a sleep physician myself, I'm always very happy to write a letter of support or advocate if needed to workplaces or employers, and sometimes it might not occur to your sleep physician or your family doctor perhaps that might be an avenue that they could help you out with, so sometimes a little bit of advocacy can go a long way. And then finally, with lifestyle considerations would be these daytime naps. So short naps can be very refreshing and may sometimes take the place or help supplement wake promoting medications. So they can be a really good tool in the arsenal as well of lifestyle changes. That's everything I wanted to talk about here. We'll have some time for a discussion period, so this recording will end, and then the real life Laurel will be here to join you in a moment. Thank you so much for your attention.
Thank you, Dr. Charlesworth. Excellent presentation. So it looks like we do have a question here. Could a person take modafinil and a stimulant as needed for that type of, for hockey practice driving type of situation?
Yeah, so that's a very fair question. The two medications together, if they're both being taken at the same time for the same purpose, my general approach personally, and as I said, this is kind of an art of medicine type of consideration, but my approach personally is usually if you're trying to take two medications for the exact same purpose, then one of those medications is probably not optimized. So usually if you're thinking about taking two together, maybe think about how to best optimize one of them before adding another. The role that that immediate release stimulant comes into play is usually for if you just need that quick burst, if there's a drive home that you usually do at 3 p.m. or a boring meeting that you usually have at 3 p.m. when somebody would otherwise have that somnolence dip. That's really where it complements the action of the modafinil. Or I used hockey practice as an example because that tends to happen later in the evening when patients need a little bit of extra protective mechanism to kind of boost them up. So I tend to try to avoid using them together. There's not a clear reason why you can't, but you would want to be a bit careful with those side effects. More so just for me, that's a bit of a red flag to tell me that I'm not fully treating this person's symptoms. And I'm a bit of a purist. I try to go for monotherapy if possible, but everyone's going to be a little bit different.
Thank you, doctor. It seems that getting prescriptions in Canada is more difficult than in the US. Can you explain why this is? And are there ways that we can work around this to get the meds that we need and our doctors are prescribing?
Yeah, so I don't have a great in-depth knowledge of that simply because I'm not as aware of the American health system. I have heard that stimulants are a little bit easier to access through various clinics in the United States, and I don't know the exact reasons or legalities or policies around that. But I will say in Canada, I find it's a little bit more challenging because there's a little bit more red tape and there's a little bit more requirements from the pharmacies for how often they can refill prescriptions, exactly how the prescriptions need to be phrased. And I find just in general, physicians up here tend to be a bit more risk averse in certain scenarios. I shouldn't overgeneralize that. And so I have found, I agree that it is sometimes challenging, especially from a family physician. They may not be as familiar with these conditions, and then finding a sleep physician to help support you may be required. I have found in my practice, I have patients who are very, very stable with narcolepsy, and I only follow them for medication represcription because the family physician is not comfortable with that. And as many of you may know, up in Canada, we are in a bit of a crisis with family physicians. And so sometimes a specialist is needed to help take a little bit of that weight and that worry and that discomfort off of the family physicians. And so it does lead to a bit of a challenge when you have if you're living in maybe an under-resourced area or somewhere where you don't have access to a sleep physician. So the one way that I may suggest to get around that is more and more e-consults are becoming popular and more accessible. So if your family physician doesn't have easy access to a sleep physician to refer you to, or a sleep physician's wait list is far too long, perhaps suggesting to the family physician that an e-consult might be an appropriate platform, and they might feel a little bit more comfortable with that, having a bit of guidance without the full consult requirement. So off the top of my head, that's the main way that I can think of ways around it. I think ultimately it's all just about safety and physicians caring for your safety and wanting to take the best care of you.
Thank you. Are there specific doctors who have expertise in narcolepsy in British Columbia? Or is it just the sleep doctors who diagnose narcolepsy? We found our sleep doctor was not really well informed or helpful, and we need to get a referral again. I don't know if you would be able to comment on that.
Yeah, I'm sorry to hear that. It must be frustrating as a patient to kind of get to that point. Unfortunately, being in Ontario, I'm not very familiar with the physicians out there. I have found purely from personal experience that most sleep physicians are usually quite comfortable with these types of medications. The sort of subclass of sleep physicians who may be a little bit more comfortable would be, for example, sleep neurologists. So if you can find a sleep neurologist to ask to be referred to, that might be reasonable. There might also be sleep neurologists available by e-consult for your family physician. I'm not too sure of what the landscape is like out there. So I don't have specific suggestions.
Thank you. Any other questions? Do you have would you be able to comment on your opinion regarding switching people from the oxybate, the sodium oxybate to the oxybate?
So as far as I know, so far, the lower sodium oxybate is not yet available in Canada. Is my understanding, at least as of a month ago. It probably is coming, as it's been recently approved in the United States. The main consideration is safety considerations for swapping over. And so it's not actually something I've done yet because it's not approved here. My understanding is that it's a 1-to-1 type of dose. And so it's probably going to be just sort of the cost and the logistical considerations. But the actual physical switching should be fairly straightforward, is my understanding. But we'll see once it's approved up here.
Mm-hmm. Do you have any patients at the college age level who are on some of the medications that you have described, to watch out for different safety issues? And how do you handle that, or what guidance do you give to those students students?
Yeah, absolutely. I have to say that the biggest thing for my adolescent and young adult age patients, number one, is really, really working with them on the non-pharmacologic side of things, because even for patients without narcolepsy, that is so hard when you're a student and trying to catch up on deadlines and things like that. So I first of all try to provide the most support that I can non-pharmacologically. And with regards to the specific medications, it's mostly just specific safety considerations would be stimulants are unfortunately a medication that can have abuse potential, particularly in academic communities. And so smaller prescriptions may be required, and a little bit closer monitoring sometimes if somebody's in a more public area, like a dorm room, that people may be coming and going, and just making sure that the patient is being very careful with that. And then the other specific consideration in the college and university age students would be particularly for people who could become pregnant is counseling on the forms of birth control as well, coming back to that. But in general, I'm not prohibited to one or the other. It's more so just working with the patients individually and acknowledging that their life situation is very much in flux at that point in time. And so providing as much counseling, both pharmacologically and non-pharmacologically, is really important for me when I'm taking care of my patients.
Okay, great. Any other questions for Dr. Charlesworth before she finishes the presentation? Last chance. No. And Dr. Murray did recommend a doctor in British Columbia that I did put in the chat for you there. So thank you. Well, I thank you, Dr. Charlesworth, and thanks for sending the pre-recorded session. That worked out great. It was very informative, and I appreciate you being here for questions as well today. So
I'm glad the internet situation worked out. It was lovely to join you.
Good. Thanks so much. Have a great rest of your day.